You are most welcome to this talk. Now, today I want to walk you through something that I find genuinely difficult to explain, and I think you will too once we look at the numbers together. What we are going to examine is a statistical error, a rather fundamental one that appears to have affected vitamin D recommendations in multiple countries for over a decade now. And what makes this particularly interesting from a public health perspective is not just that the error was made, because errors happen, we all make mistakes, but that it has persisted for so long without correction. So let me show you the data and you can draw your own conclusions about what this might mean. Now, before we go any further, I want to be very clear about what this video is and what it is not. This is an educational discussion about publicly available research and how to interpret statistical methodology in nutritional science. This is not medical advice. I am not telling you what dose of anything to take. If you have concerns about your vitamin D status or any other aspect of your health, please speak with a qualified healthcare professional who knows your individual circumstances. What we are doing here is learning how to read scientific papers critically, which I think is an essential skill for everyone in this day and age. Right, so let me show you where this is all coming from. The paper I want to discuss with you today was published back in 2014. And it is titled "A Statistical Error in the Estimation of the Recommended Dietary Allowance for Vitamin D." Now, this paper made quite a specific claim. The authors argued that the Institute of Medicine in the United States, which is now called the National Academy of Medicine, made what they describe as a fundamental statistical error when calculating how much vitamin D people need. And we are going to look at exactly what that error was and why it matters. So first let me give you the bottom line and then we will work through the details. According to this paper, the recommended amount of vitamin D in the United States may be approximately 15 times lower than what would actually be needed to achieve the stated health targets. And in the United Kingdom, where the recommendation is even lower at only 400 international units per day compared to 600 in the United States, the recommendation may be around 22 times lower than necessary. Now, those are extraordinary claims. And extraordinary claims require careful examination of the evidence. Let me explain what the Institute of Medicine was trying to achieve. Their goal was to establish a recommended dietary allowance that would ensure 97.5% of the population achieved adequate vitamin D status. This is standard methodology in nutritional science. You do not just aim for the average person to be adequate, you want the vast majority of the population to reach healthy levels. And the target they were working towards was a blood level of vitamin D, specifically 25-hydroxyvitamin D, of at least 50 nanomoles per litre. That is the threshold generally considered necessary for bone health and prevention of deficiency diseases like rickets. Now, what did they conclude? The Institute of Medicine concluded that a daily intake of 600 international units of vitamin D would be sufficient to get 97.5% of the population to that target level. And based on that conclusion, public health recommendations were set. The United States went with 600 international units for most age groups, and the United Kingdom, interestingly, went with a slightly lower figure of 400 international units. Why exactly the United Kingdom chose a lower number when both should theoretically be based on the same underlying science is something I have never quite understood, but that is a separate question. So what went wrong? Well, according to this 2014 paper, the error is something statisticians call the average versus individual mistake. And actually, this is quite a fundamental concept in statistics that even those of us without advanced training can understand when it is explained clearly. Let me try to make this as simple as I can. When the Institute of Medicine looked at this question, they examined 10 different supplementation studies that had been conducted during winter months. These studies were done in locations above the 50th parallel, where people would not be making significant amounts of vitamin D from sunlight. That part of their methodology makes sense. You want to know what happens when people are not getting vitamin D from the sun, only from supplements and diet. Now, here is where the problem occurred. Instead of extracting the individual data points from all participants in all these studies and analysing them together, what they apparently did was take the average results from each study and then analyse those averages. And you might think, well, what is the difference? Surely the average of averages gives you the same answer. But it does not. And this is the crucial point. Let me try to explain this with an analogy that might make it clearer. Imagine you are a teacher and you want to set a curriculum that ensures 97.5% of students pass the exam. One way to do this would be to look at all the individual student scores from multiple classrooms, see the full range of how students perform, and design your curriculum to ensure that all but a small percentage will succeed. That would be analysing individual data. But what if instead you only looked at the average score from each classroom? The thing is, there is much less variation between classroom averages than there is between individual students. Some classrooms might have an average of 70%, others might have 75%, but within each classroom you have some students scoring 90% and others scoring 40%. By looking only at the averages, you smooth out all that individual variation. So if you design your curriculum to ensure 97.5% of classroom averages meet the standard, you are not actually ensuring 97.5% of individual students meet the standard. You might have many classrooms where the average is fine, but where plenty of individual students are failing. And that is essentially what this paper claims happened with the vitamin D calculations. When the Institute of Medicine used study averages instead of individual data, they inadvertently created a statistical artifact. The variation they were measuring was the variation between study averages, not the much larger variation between individual people. And when you calculate a recommended dose based on that smaller, smoothed out variation, you end up with a dose that is far too low to actually achieve your goal for individuals. Now let me show you what the numbers actually look like according to this paper. The Institute of Medicine thought that giving people 600 international units of vitamin D per day would result in 97.5% of the population achieving blood levels of around 63 nanomoles per litre. That was their calculation. But when the authors of this paper recalculated using the correct statistical approach, looking at individual variation rather than study averages, they found something quite different. According to their recalculation, 600 international units per day would actually result in 97.5% of the population achieving blood levels of only about 26.8 nanomoles per litre. That is less than half of the target level. In fact, a level of 26.8 nanomoles per litre is well within what is generally considered the deficient range. So instead of getting nearly everyone to adequate levels, we would be getting nearly everyone to levels that are still deficient. And if you want to know what dose would actually be needed to get 97.5% of the population to that 50 nanomole per litre threshold, the paper suggests it would be somewhere around 8,895 international units per day. Now, I want to be careful here because that is obviously a very different number from current recommendations, and it raises all sorts of questions that we need to think about carefully. Let me pause here and talk about methodology for a moment because this is important. When we read any scientific paper, we need to think critically about its claims. The authors of this paper are making a very specific accusation that a major scientific institution made a basic statistical error. That is a significant claim. Now, the paper was published in a peer-reviewed journal, which means other experts in the field reviewed it and found it worthy of publication. That gives it some credibility. But it is still just one paper, and we should always be cautious about accepting any single study's conclusions uncritically. What I would want to see, and what I think any thoughtful reader would want to see, is independent verification of this claim. Have other statisticians examined the Institute of Medicine's methodology and come to similar conclusions? Have the original authors or the Institute of Medicine itself responded to this criticism? What does the broader scientific community think about these claims? These are all questions worth investigating. I should also note that there is another paper which has been quite widely cited called The Big Vitamin D Mistake, which appears to support similar conclusions. So this is not an isolated claim from a single group of researchers, but equally it has not led to changes in official recommendations, which might suggest that regulatory bodies have reasons for maintaining their current positions. We should be open to the possibility that there are considerations we are not fully aware of. Now, let us think about what this means in practical terms, assuming for the sake of discussion that the paper's calculations are correct. If you live in a country like the United Kingdom or Canada where you are above the 50th parallel, You are not going to make any significant amount of vitamin D from sunlight during the winter months. The sun simply is not strong enough. And in the United Kingdom, to be clear, the entirety of the country is above the 51st parallel. So this applies to everyone. According to estimates, the average dietary intake of vitamin D in many populations is somewhere around 200 to 300 international units per day. That comes from foods like oily fish, eggs, fortified products, and so on. But most people are not eating large amounts of cod liver oil, which is one of the richest natural sources. So if the diet provides, let us say, 250 units, and people are not making any from sunlight in winter, they are getting nowhere near even the current recommended amount of 400 or 600 units, let alone the much higher amounts this paper suggests might be needed. What are the potential consequences of vitamin D deficiency? Well, this is something we should approach carefully. The most well-established effects are on bone health. Severe vitamin D deficiency causes rickets in children and osteomalacia in adults. This is not controversial. Vitamin D is essential for calcium absorption and bone mineralization. That is well-documented science. Beyond bone health, there is a large body of observational research suggesting associations between vitamin D status and many other health outcomes. Studies have found correlations with immune function, with cardiovascular disease risk, with diabetes, with certain cancers, and with cognitive function and dementia risk. But I want to emphasize the word correlations here because correlation is not causation. When we see that people with lower vitamin D levels have higher rates of certain diseases, there are multiple possible explanations. It might be that low vitamin D causes those diseases, but it might also be that having those diseases causes low vitamin D levels, or it might be that both low vitamin D and the diseases are caused by some third factor, like reduced outdoor activity, poor overall nutrition, or chronic illness. Observational studies cannot distinguish between these possibilities. What we really need are large, well-designed randomized controlled trials where some people are given vitamin D supplementation and others are given placebo, and we follow them over time to see if the supplementation prevents disease. Some such trials have been done, but the results have been mixed. Some show benefits in certain outcomes, others do not. The picture is complicated, and we should be honest about that complexity rather than oversimplifying in either direction. Now, let me address something that I think is a reasonable question. If this error was really made, and if it was identified back in 2014, why has it not been corrected? That is 11 years now. Surely if there was a clear mistake in the calculations, the relevant authorities would have reviewed their recommendations and made adjustments. Honestly, I do not have a good answer to that question. There could be various explanations. Perhaps the relevant bodies have reviewed the criticism and concluded that their original methodology was actually correct. Perhaps there are bureaucratic or institutional barriers to changing established recommendations. Perhaps there are concerns about the safety of recommending higher doses that have not been adequately tested in large trials. Perhaps there are considerations we are simply not privy to. I want to be careful not to assume the worst or to suggest that there is some deliberate attempt to keep people unhealthy. I do not think that is a reasonable conclusion from the available evidence, but I do think it is fair to say that the apparent lack of response to this criticism is puzzling and deserves explanation. When scientific errors are identified, we would hope that they would be addressed promptly and transparently. Let me also mention the question of upper limits. Current guidelines in many countries suggest that 4,000 international units per day is the tolerable upper limit for vitamin D supplementation. If it turns out that the amount needed for most people to achieve adequate blood levels is nearly 9,000 units per day, that obviously raises questions about whether the upper limit needs to be revisited as well. But again, we should be cautious here. The upper limits are set based on safety data, and there have been concerns about potential toxicity from very high vitamin D intakes, including hypercalcemia, which is elevated calcium in the blood. The relationship between vitamin D intake, blood levels and toxicity is complicated by individual variation. Some people may efficiently convert vitamin D and achieve high blood levels from modest intake, while others may need much more. There are genetic factors, there are factors related to body weight and fat mass, there are factors related to kidney and liver function. This is not a simple one-size-fits-all situation. So what do we actually know and what do we not know? Let me try to summarize. What we know is that vitamin D is essential for bone health and that severe deficiency causes disease. We know that many people, particularly in northern latitudes during winter, have blood levels below what is currently considered optimal. We know that there are observational associations between vitamin D status and many health outcomes beyond bone health, though causation is not established. We also know that a respected peer-reviewed paper has identified what appears to be a statistical error in the methodology used to establish current recommendations. That paper has not been retracted, and similar concerns have been raised by other researchers in subsequent publications. The specific error alleged is a confusion between population averages and individual variation, which is a recognized problem in statistics. What we do not know is why official recommendations have not been updated in response to this criticism. We do not know with certainty whether higher vitamin D intakes would improve health outcomes in the general population. We do not know the optimal blood level of vitamin D for various health outcomes beyond bone health. And we do not know the long-term safety of vitamin D intakes significantly higher than current recommendations. If you are watching this and wondering what you should actually do, here is what I would suggest. And remember, this is not medical advice. If you are concerned about your vitamin D status, the first step would be to discuss this with your doctor. You can ask to have your blood level tested. The test for 25-hydroxyvitamin D is straightforward and widely available. Once you know your actual level, you and your doctor can make an informed decision about whether supplementation is appropriate for you and at what dose. You might also ask your doctor what they think about the research we have discussed today. Different healthcare providers may have different views, and that is fine. Medicine is not a field where everyone agrees on everything. What matters is having an informed conversation based on your individual circumstances. I think there is also a broader point here about how we approach nutritional science and public health recommendations. We tend to treat these recommendations as if they are settled facts, but they are really our best current estimates based on imperfect evidence and imperfect analysis. They can and should be updated as new evidence emerges or as errors are identified. That is how science is supposed to work. And if there has been a reluctance to update vitamin D recommendations in the face of valid criticism, that is concerning, regardless of what the correct answer turns out to be. One more thing I want to mention. This paper specifically looked at the amount of vitamin D needed to achieve blood levels associated with bone health. But some researchers argue that the targets themselves might be too low. 50 nanomoles per litre might be adequate to prevent rickets, an obvious bone disease, but optimal levels for other aspects of health might be higher. This is an active area of research and debate, and again we should acknowledge that uncertainty rather than pretending we have all the answers. What I hope you take away from this video is not necessarily a specific conclusion about vitamin D doses, but rather an appreciation for how important it is to understand the methodology behind scientific recommendations. A simple statistical error, if that is indeed what happened here, could have profound implications for millions of people over many years. It shows why we need transparency in how these calculations are done and why we need mechanisms for identifying and correcting errors when they occur. I find this topic fascinating from an educational perspective because it illustrates so many important principles: the difference between population averages and individual variation, the importance of going back to original data rather than just summarizing summaries, the challenges of translating scientific evidence into practical recommendation, and the sometimes puzzling persistence of apparent errors in scientific literature. These are lessons that apply far beyond vitamin D to how we interpret any scientific recommendation or guideline. Alright, I think I have covered the main points I wanted to make. To summarize very briefly, a paper from 2014 claimed that vitamin D recommendations were calculated using an incorrect statistical method, using averages of studies rather than individual data, and that the correct calculations would suggest needs are many times higher than current recommendations. This claim has not been formally addressed or refuted that I am aware of, and recommendations have not changed. The implications, if the paper is correct, would be significant for public health. This video is for educational and informational purposes only. It is not medical advice. If you have symptoms or concerns, please consult a qualified healthcare professional. We use publicly available data and reputable sources, and interpretations may evolve as new evidence emerges. I would encourage you to look up this paper yourself if you are interested. It is publicly available, and reading primary sources is always better than relying on summaries, including my own summary here today. Science literacy means engaging directly with the evidence and forming your own informed views. Thank you for watching, and I will see you in the next video.